My name is David Hoganson. I'm one of the pediatric cardiac surgeons here at Boston Children's Hospital. It's my pleasure to participate in this conference. I'm going to share with you some of our efforts in using 3D modeling and flow simulation for preoperative planning in patients with heterotaxy and complex congenital heart disease. Just some disclosures about some gift-in-kind software that we use from Dassault Systems and other software providers, and certainly a lot of what we'll talk about is off-label use. It's going to start with a patient. They sort of highlight some of the challenges that we have in patients with heterotaxy and congenital heart disease, as well as some of the ways we're using some of these advanced technologies to help understand and plan the right thing to do in these patients. So this is a patient who is a 4-year-old with heterotaxy, right-sided polysplenia, who has hypoplastic left heart syndrome with mitral stenosis and aortic atresia, and also has systemic venous abnormalities of an interrupted inferior vena cava with azygous continuation. And this patient underwent initially a stage 1 operation as a neonate, and then as an infant, he underwent a Glenn operation with anastomosis of the superior vena cava to the pulmonary arteries, and we left the azygous vein draining into the right atrium because he was a little bit young and the pulmonary arteries were a little bit small for Kawashima. And then as a 4-year-old presented for Fontan, but given the anatomy and particularly the systemic venous abnormalities, was at high risk for hepatic venous flow maldistribution to the lungs. And you can see here on the right the 3D model that was created from the MRI that highlights some of the features of his anatomy. And this is looking at the 3D model with just the pulmonary arteries and the right atrium shown. And you can see here on the left side of the screen the Glenn connection to the pulmonary arteries viewed from the front. And here, this is the right atrium added to that image, and you can see the relationship between the right atrium and the pulmonary arteries. And then here on the right, you can see the azygous vein that courses over that right pulmonary artery and connects to the right atrium. And you can see the relationships here and the complexities of what we need to consider as we think about how to do a Fontan completion in this child. And so the question then was, what Fontan operation gives adequate balance of blood flow to the lungs as well as low energy loss? And so certainly the first or standard consideration would be a lateral tunnel or extracardiac Fontan that incorporates the hepatic veins up into the pulmonary arteries. And also certainly we need to connect that azygous vein to the pulmonary arteries also. So that was one consideration. But then another question was something like an hepatoazygous shunt, where we bring the hepatic veins directly back to the azygous vein and then incorporate the azygous vein into the pulmonary arteries. Would that be a better option for this child, building on some of the experiences of other patients with interrupted inferior vena cava that we treated here at our center? And so really the goal is to achieve both low energy loss and then balance of the hepatic venous return to both lungs to avoid pulmonary arteriovenous malformations, which can occur in these patients, particularly patients with interrupted inferior vena cava, where all the blood flow from the liver can be directed towards one lung, and in the other lung is pulmonary avios can form. So certainly this is a principal goal to avoid in these patients. I'm going to share with you some of the workflows that we have utilized with these 3D models and the sort of process we go about in making them. So this is where the 3D models, they start from a CT scan or an MRI, and then from that we undergo a process called segmentation, which is a semi-manual process. We have a team of engineers that create these models for us, and then we have a digital 3D model of the patient's hearts. We used to 3D print these. We no longer do. We haven't for many years. We use them as sort of an all digital workflow. From the digital model, we can use them for preoperative planning and intraoperative guidance. We can also use them as a substrate for virtual surgery and planning different quantitative reconstructions like patch reconstructions. And then we can also use them to study the flow inside the heart with different surgical options, and then try to make the best decisions based upon that information. So this highlights a different patient with heterotaxy. This is a patient with dextrocardia and bilateral superior vena cava. And just highlight some of the different ways we can look at the anatomy with these 3D models. This patient has a left dominant AV canal, left IVC, and almost right upper pulmonary veins. Another pulmonary venous confluence, and had stent in his right ventricular outflow tract. And so you can see how these 3D models really give us a unique perspective on the anatomy and the different relationships between the anatomical features, and they've really become a mainstay for how we plan and carry out these complex reconstructions in heterotoxic patients. We use the 3D models both before surgery as well as an intraoperative guidance tool, and we've reprogrammed several Nintendo switch controllers, and we're able to manipulate the model from the field and the screen in front of us and achieve any combination of anatomical features and views either inside or outside the heart to help guide us as we do these operations. We also use the models as part of an intraoperative conduction mapping program that's spearheaded by one of our other surgeons, Eric Fines, and two cardiologists that have really allowed us to use an EP conductance mapping catheter in the operating room in these patients, particularly patients undergoing biventricular repairs where VSD closure or a baffle could put the conduction system at risk. And not only are we able to identify the connection system in these patients, but we use the 3D models as a way to really annotate for each individual patient where the conduction system is found. And that's been extremely useful. And so in addition to the 3D models to represent the anatomy and be able to study it in a very intricate and quantitative way, we also use the 3D models as the substrate to plan reconstructions. And shown here is sort of the steps that we do that, where we take the 3D model of the patient's own anatomy and then design reconstructions such as a patch inside the heart or in one of the blood vessels. And this takes into account both the geometry and then some of the mechanical properties of either the patch material and the cardiac structures. And then often these patches are curved, and so there's a mathematical algorithm to create sort of the flat patch equivalent, because most of our patch materials start as flat materials. And then we're able to translate that patch design into the operating room with a laser system that shines the patch design down on the patch, so we can trace it out, cut it out with scissors, and then use it during the reconstruction. We also do virtual surgery for Fontan completions or Fontan revision operations, as you saw in the single ventricle heterotaxy patient we discussed a bit ago. And this highlights a patient with a complex ventricular septal defect that similar to what we often see in heterotaxy patients. And in this particular patient, there was a large membranous VSD with a coronal ventricular extension. And this included some narrowing of the path to the aorta. And this represented a challenge to decide exactly how to both go about shaping the VSD patch as well as removing some of that obstructing tissue below the aortic valve. And in this patient, we were able to design the 3D patch for this patient. Also, with virtual surgery, remove some of that tissue below the aortic valve and plan exactly how we would do that. And we're able to come up with a three-dimensional patch shape for this patient. And this just highlights a couple different views of this VSD patch, and certainly the both the curvature and the shape of the patch. You can see it's not planar by any means, and you can appreciate the challenge of shaping this just the right way in the operating room. And so doing this beforehand can be super helpful, particularly noting the annotations of how the patch will need to be aligned with the different structures, the tricuspid valve and aortic valve, for example. And then we're able to create the flat patch equivalent with this 3D experience tool that's used in aerospace engineering, and not only get the dimensions of that flattened patch equivalent, but also annotate on that patch exactly how it's going to line up with the different anatomical features. And then we're able to use a laser projection system that we borrowed from the aerospace industry that is very common there, and project the patch design down on the patch material. And we've studied this carefully in different patch materials and shown there's less than 2% error between the patch design and the patch size after it's traced out over the laser pattern and then cut out with scissors. So this is a really nice way to translate that carefully designed patch onto the sterile patch material in the operating room. And then another way we're using this 3D model workflows is to simulate the flow through the heart, particularly in single ventricle patients. And so from this, we again start with the patient's own 3D model, and then we model different surgical options, often Fontan revisions or completions. And then we take the patient's own physiologic data from their MRI and cath data. And then we do a computer simulation of how we expect the flow to go through the different anatomies used in the patient's own physiology. So this isn't simulating the flow in general. This is simulating what we actually expect for this individual patient, including utilizing their expected resistance of blood flow through the lungs for these single ventricle patients. And then we're able to analyze the flow simulation results, and from that, understand what's the best option for low energy loss and good distribution of blood flow to both lungs. And then we use that selected plan for intraoperative guidance when we do these surgeries. And so one important thing that we've learned is that usually for these small children, the information from the cath and the MRI are obtained when the patients are under anesthesia. But it's really important to model the circulation under several different physiologic conditions to really have a robust analysis and then really understand how the flow is going to be in real life. And of course, nobody lives under anesthesia. And so we really want the Fontan circulation to work well under normal resting physiology after the child eats and when the child exercises. So we're able to plan that out and test that physiology under different conditions to really know how robust of a surgical solution are we proposing. And so if we can jump back to that patient we first talked about, this 4-year-old with heterotaxy and right-sided polysplenia, hypoplastic left heart syndrome, who underwent the stage 1 and then the Glenn. Now we're trying to understand what is the best option for Fontan in this patient. And this demonstrates the hepatic flow distribution for lateral tunnel or an extracardiac kind of a connection where the hepatic veins are connected directly up underneath the pulmonary arteries, and then that azygous vein is also connected to the right pulmonary artery. And what this shows is under normal resting conditions, the hepatic venous flow would be really skewed towards the right lung. And so it looks here like we expect 90% of the hepatic venous flow to go to the right lung and only 10% to the left lung under normal resting conditions. After eating, it's a little bit better with 20% of the blood flow going to the left lung because the overall liver flow after you eat goes up substantially. But with exercise, we would predict 100% of hepatic venous return to go to the right lung. Nobody knows the minimal amount of hepatic flow to one lung that's necessary to prevent AVMs, but we typically shoot for at least 20% or more to one lung, and ideally it would be much closer to well balanced, particularly for a patient who's not a Fontan revision but undergoing their initial Fontan operation. So we knew we needed to make some changes and look at other options in this patient. And so then we asked the question of what about a hepatoazygous shunt, where the hepatic veins are connected directly back to the azygous vein. Often in these patients with interrupted inferior vena cava, that's a good option. Just given the individual features of this patient anatomy and how we expected we would incorporate that azygous vein into the pulmonary arteries also, to give us a picture of what that might look like. And it definitely was better with 81% of the flow from the hepatic veins going to the right lung and 19% to the left lung under normal resting conditions. Again, a little bit better with postprandial and exercise, but this was still, riding a sort of a little bit of a narrow margin on being sufficient for this patient. And so we want to take it one step further and say, could we change the flow a little bit to make it even a little bit better? And if you, as you can see here, it's really sort of a situation where the blood that comes down from the superior vena cava mostly goes to the right lung, and the blood flow that comes up from the azygos, or excuse me, mostly the left lung, the blood that comes up from the azygos goes mostly to the right lung. And so we wanted to see if we could improve the mixing where the superior vena cava and the azygos came together. And so what we did is we designed a patch to add to that area that would allow that those streams to cross and have better mixing of that hepatic venous flow. We were able to dimension that patch, get the flat patch equivalent, and be ready to use that in the operating room. That did improve the expected flow conditions. And so when we looked at this again with the flow simulation, now we had a substantial improvement. And so if you look at normal resting conditions, now 63% of hepatic venous flow went to the right lung and 37% to the left lung. So this is much better. And this was the option we chose to pursue in this patient. So, and then for all these patients who we do this flow simulation before surgery, we also do a repeat MRI after surgery, so we can really understand what the outcome was, and if our analysis really well predicted what would be the outcome. So if you look at the upper chart for this patient, the hepatic flow distribution predicted was 63 to the right lung and 37% to the left. Post-op, when we reran the analysis with the post-op anatomy, we got 70% to the right and 30% to the left, so pretty close. And the total flow distribution to the lungs, we predicted 57 and 43, and the MRI gave us 51 and 49. So again, quite close to our predictions and a really nice outcome for this complex patient who's clinically done very well. And then we've done this in many other patients, and this just gives you a sense for some of the other challenges we see in these complex single ventricle patients with heterotaxy. This patient also had an interrupted IVC and azygos continuation, but with bilateral superior vena cava, which is a really challenging situation and what to do. And so what was initially proposed is we would do a standard Fontan in this patient, but as you can see in the pictures B and C, this resulted in all or nearly all the hepatic venous blood going to the left lung. And so in this patient, we did do a hepatoazygos shunt, and that resulted in a pretty nice distribution of 52 and 48% shown here in F. And the child underwent that operation and had a really nice outcome. And so this has been used in many of these complex patients to really predict the best approach as shown here. And we've worked very hard to validate the computational fluid dynamics flow simulations in these Fontan patients, and we get MRI follow-up in all these patients. And this is just a group of 4 patients with interrupted IVC and azygos continuation, which we often see in these heterotaxy patients. And the overall flow balance in these 4 patients, the CFT model predicted 51 to the right and 49 to the left, plus or minus 5%. And the post-op MRI was very similar at 49% to the right, plus or minus 8%. So our really hard work to try to define the patient's individual physiology with cath and MRI data has paid off well, with really nice similarities between what we're predicting by the flow simulation and what we're getting by MRI after the surgery. Also want to share with you another 3D modeling effort we've done in these patients, which is trying to model their AV valves. And certainly these patients, many heterotaxy patients have a complete AV canal anatomy or other features of their AV valves, which make them challenging to both understand and repair. And so similar to the 3D models you've seen earlier, we're also now able to model the AV valves, either a canal type AV valve or a regular AV valve. And that's given us tremendous information about the leaflet structure, the annular structure, and the subvalvular structure. And you can see here, we can get sort of any view of these valves using this 3D viewer. that is a web-based viewer, and we're able to make measurements of the valve, such as the portal lengths, and understand the relationships between the leaflets, and then really use all these dimensions to start to plan what we're going to do in the operating room to best repair these valves. We have a big team of engineers and that make the valves, or excuse me, make the 3D models, including Rena, who's a cardiologist who focuses on valve modeling. And this team of engineers both creates the 3D models and then does the engineering work to plan patches and perform flow simulation and validate these workflows in the lab prior to clinical use.